Good afternoon, everyone, and thank you for joining us today. I'm very pleased to welcome you to a discussion of what the end of the COVID-19 public health emergency means for opioid use disorder treatment and access to treatment across the country. Move to the next slide. I'm Karen Scott, president of the Foundation for Opioid Response Efforts, and we're thrilled to partner with Manat Health on this webinar this afternoon, as well as an issue brief, which will be coming out shortly to really delve into this question about what comes next for OUD access to treatment. By way of introduction about the Foundation for Opioid Response Efforts, we are a national grant-making foundation that was launched in 2018 to support solutions to the opioid crisis. Since that time, we've developed projects that support work addressing professional education, payer and provider strategies, policy initiatives, and improving public awareness. And we've done that with top programmatic areas of focus that include access to treatment, supporting recovery services during the early months of the COVID-19 pandemic, supporting a program focused on innovation, particularly around data and addressing stigma, family-based prevention programs, and most recently launched a program to build capacity in community-based organizations. All told to date, we've awarded 89 grants and a bit over $36 million committed to the programmatic efforts that I just mentioned. But our first round of funding was actually announced in early March 2020, and those were our first set of projects focused on improving access to treatment for high-risk and vulnerable populations. Within days, as you might recall, it was clear to us that the way we had envisioned those projects with our brand new grantees was going to change pretty rapidly and pretty significantly as we all began to absorb what the COVID-19 pandemic would mean and how all-encompassing that would be. We turned to Manat Health, to the team at Manat Health, to help us understand some of the brand new temporary policies which were emerging to help maintain access to treatment for people with opioid use disorder. And we also turned to our brand new grantees who were persevering in this work. We've learned a lot over the past 3 years working with all of these colleagues, and 3 years on, we thought it would be appropriate and timely to bring people back together, assess what the end of the COVID public health emergency means for what we've learned during the past 3 years and how we can continue to improve access to treatment for opioid use disorder. I'm very pleased to welcome this afternoon our panelists, Zoe Bernard, who's Senior Advisor at Manat Health. We're joined by national leadership, Beth Connolly, who's Assistant Director in the Office of Public Health and the Office of National Drug Control and Policy, in the Executive Office of the President. Dr. Andrew Herring, Founder and Director of California Bridge and Chief of Addiction Medicine at Alameda Health System. Danielle Russell, Dr. Danielle Russell, Arizona State University researcher and a person with lived experience with the treatment system, and Hemi Tewerson, who's Executive Director of the National Academy for State Health Policy. We will start with turning to Zoe Bernard to give us an overview of what some of the policy changes have been during COVID, and at this point, what stays the same, what changes again, and what we need to be looking out for as next steps. So thank you all for joining us again, and I'll turn it over to Zoe.
Thank you so much, Karen. I'm going to spend a little bit of time just going through some of the flexibilities that emerged during the COVID-19 pandemic and talking about the status of current regulations. I'm going to go through these slides relatively quickly in the interest of time, so I would like to highlight that they will be available post-webinar if you would like to study the policy changes more carefully. So to begin with, wanting to highlight, there are three main things that have changed a great deal at the federal level. And those are allowance for telehealth, provider registration with the DEA and removal of the X waiver, and the ability for OTPs to allow take-home doses. And highlighting on this slide that during the pandemic, the overdose death rate increased pretty dramatically, and it impacted certain subpopulations a great deal more than others. In particular, American Indian and Native people, Black people, and adolescents. Let's go to the next slide. And the next. So in terms of telehealth, as you all will recall, thinking back to March 2020, as the pandemic was starting, the Drug Enforcement Administration suspended the in-person requirement for providers in terms of prescribing, which gave an opportunity for people to receive medications for opioid use disorder, regardless of where they lived, assuming that their state laws would allow this. And wanting to highlight here that incorporation of telehealth technology with MOUD is associated with patients being happier, staying in treatment, reducing healthcare costs, increasing usage of medications, and increasing engagement with patients. On the right-hand side of this slide, you can see the changes that occurred throughout the duration of the pandemic and prior to the pandemic, noting that in February of 2023, the DEA issued a proposed rule that really limited some of the telehealth flexibilities. In particular, would have required patients that had established a telehealth-only relationship with their physician to be seen for a medical examination. And the DEA received a record over 38,000 comments on that proposed rule, and as of May 10th, has filed a temporary rule which extends the full set of telemedicine flexibilities for the prescription of controlled medications through this November. And any practitioner-patient relationship that was established before November 11th, 2023 will continue to be permitted through November 11th, 2024. This is really important because it prevents a backlog of in-person examinations, and quite frankly, for some people who can't even get to an exam, allows them to continue to receive life-saving treatment. Next slide. The X waiver. Although the X waiver was not connected to the pandemic in particular, the Consolidated Appropriations Act of 2023 removed the X waiver requirement, and so the timelines associated with the removal of the X waiver correspond to the changes associated with the pandemic. And the situation as it stands now is that providers who wish to provide medications for opioid use disorder, in particular buprenorphine, outside an OTP clinic can do so. They just need a standard DEA registration number, and there is no longer a 30-patient cap on the number of patients that a provider may see. Effective this June, there will be 8 hours of training that's going to be required for all prescribers. This should normalize providers treating opioid use disorder. Next slide. Regarding take-home doses, there was a lot of concern about take-home doses at the beginning of the pandemic, and a concern that patients who are receiving methadone should not be allowed the flexibility to take home their doses of methadone. But under a bit of kerfluffle, there was a decision made that states could request exemptions to permit OTPs to dispense take-home doses of methadone. And we now know, because of the research that has been done during the pandemic, research that was cited by SAMHSA in its temporary rule, that take-home flexibility is supported by what was seen during the pandemic. The increase in take-home methadone did not result in an increase in harm. It was not a problem with diversion. Patients, especially those living in rural communities or long distances from an OTP, vastly preferred take-home doses, and that really eliminated access barriers. Super important knowledge that came out as a result of the pandemic. The post-pandemic federal landscape looks as follows. As far as telehealth, I noted that the prescribing flexibilities will be extended for 6 months. As far as registration, providers no longer need an X waiver, but they're going to have to take an 8-hour class starting in June. As far as take home, SAMHSA issued some guidance late in April that is very specific about take home doses of methadone. And that guidance is referenced in these slides. And we do have a list of references at this set of the slides for you all to look at. Last slide, go ahead. With regard to state level flexibilities, just wanted to spend just a minute looking at state level flexibilities. States really varied in the extent to which they embraced the federal flexibilities. And states really do have a lot of choice here with regard to how they choose to restrict or allow access to medications for opioid use disorder. And this may cause additional confusion post-pandemic. Take-home doses, most states did during the pandemic request exceptions to allow OCPs to provide take-home doses. Our recommendation to folks who are wondering is to seek out your state opioid treatment authority and ask them about current guidance in the state if you are unclear. The federal government has permitted advanced practice providers to do most of the things related to MOUD. During the pandemic, many states modified their licensing requirements and scope of practice laws. Because some states have retained those flexibilities and others have not, it's a good idea to check in your state of practice. And finally, during the pandemic, there was a large increase in state temporary waivers of telehealth coverage. And states are still in the process of adopting a range of licensure flexibilities for telehealth, including interstate compacts, licensure endorsement, and special telehealth registries. And with that, I'm going to move on and turn it back over to Karen and Beth.
Zoe, thank you. And I am pleased to turn the, thank you. And thank you so much, Zoe, for setting us up. I'm very pleased to turn the podium over to Beth from the Office of National Drug Control Policy. I do want to I was remiss in not asking people to post their questions in the Q&A part of the Zoom bar at the bottom of your screen. That will allow us to keep track of questions. Additionally, while we have Beth with us, if you have any questions that we can incorporate into my discussion with her following her remarks, yeah, feel free to go ahead and put those in the Q&A during her talk. Thank you, Beth.
Thank you so much, Karen, and thank you to Fore and Manat for putting this all together. I'm really happy to speak with you all today. I've been scrolling through the participants, and I see some folks that I know from my time in this space. And I just, at the White House, we don't have access to the chat. So if you chat me a private message, I won't see it. So please don't be offended if I do not reply, because I have no access to the chat here. So I'm going to start by just giving you a quick overview of the Office of National Drug Control Policy for folks who aren't familiar. So we have been operational since 1989, and we are the principal drug policy advisor to the White House and to the President. We manage a national drug control budget of $42.5 billion, and I can tell you that more than half of that is focused in the area of public health, which is a change from years past, and we're very proud of that. There are 19 national drug control program agencies, and they range from Health and Human Services to education, some of your likely suspects, to the Department of Labor, Homeland Security, Department of Justice. There are 19 in all. And so I want to start, and I know this is a treatment discussion, but I really want to start with harm reduction, because when we think about the ways that treatment has increased and the ways we've been accessing treatment during the pandemic, we really came to it from a harm reduction approach, right? Meeting people where they are. How can we meet the needs of people? And we've been trying to carry that theme through in all the policies we've been making. In the State of the Union address, the president made it very clear that he wanted to reduce the barriers to treatment, especially those that were regulatory. How can we better let people access treatment, meet them where they are, bring it to them? And so harm reduction also, for the first time mentioned in the president's first State of the Union address, has become, an important part of the discussion. And so in terms of harm reduction, we're really looking at increasing access to low barrier treatment. And harm reduction programs can actually be a good place to start that access to low barrier treatment. We know folks are comfortable at harm reduction programming. They can receive a variety of services, from some healthcare type services, fentanyl test strips, which are important and can be paid for with federal money, and naloxone access. And naloxone access is so important, and we've been doing a lot of work and will continue to do a lot of work in increasing access to naloxone, especially given the increase in synthetic opioids, including fentanyl. Just for a little bit of naloxone information, in case you missed it, in April, the FDA made one form of naloxone, the Narcan form of naloxone, non-prescription or over-the-counter, and we should be seeing that on shelves sometime this summer. We've also been having states, through their SOAR grants, submit plans on how they will assess, acquire, and distribute naloxone in their communities, especially to the communities that are most at need. And finally, we've been working a lot in the area of harm reduction to set up some strategic principles, and SAMHSA has convened a group of folks in the harm reduction space, folks with experience, to really start and plot out a strategic direction. And so some of those principles in that strategic direction will be coming out, hopefully, by the end of the summer. But again, as from the harm reduction principles of meeting people where they are, this is where we're trying to go, because we know that will help increase access to treatment. Thank you to Zoe for that great overview of the public health emergency relaxations, regulatory relaxations, and some things that have happened in the past month or so. So as she mentioned, in terms of buprenorphine, we, under the omnibus, the MATE Act and the MAT Act were both pieces of that. So the MAT Act is the piece of legislation that rescinded the requirement for the X waiver. In tandem with that, there was the MATE Act. And so the MATE Act is the part that requires the 8 hours of training for anyone with a controlled substances license. So this will happen as you apply for your initial controlled substances license or as you renew. And this 8 hours is really, it's not 8 hours straight. There are a lot of free courses that are available at the SAMHSA website, but also if you are already a prescriber with an X waiver, you already have your 8 hours. If you've been taking courses, CMEs, because your state boards requires it, and you have 8 hours, those will also count. So I think, as we've been talking to a lot of physicians, there are a lot of folks who, if they weren't X waivered, had a lot of training in these areas because it's been so important. And so a lot of their hours will already count, and they can just attest to that to the DEA. In terms of what we're pushing on, we're also trying to have more specialty settings include buprenorphine, because buprenorphine is something that can be received in an office-based setting, unlike methadone. And so we're really trying to increase access to buprenorphine in specialty settings. So thinking about emergency departments, OBGYN, in community health clinics, So where are people coming to already see a physician where they might feel most comfortable, because we know people are comfortable with their medical provider, then we'll be having more success with treatment. In terms of methadone, we have been examining not just what's been in the rule that SAMHSA has been working on, the methadone expansion rule, but also what other avenues can we go down to expand access to methadone. We see that there's been some very preliminary evidence that methadone is a preferable treatment to buprenorphine for folks who've been using fentanyl. So we want to make sure that treatment with methadone is more accessible. One way is mobile methadone vans. So during the public health emergency, a 17-year moratorium on mobile methadone vans was lifted, and it's been allowed now that states can purchase and provide methadone via this mobile option, which is good in any number of settings. One thing that's important to know is that I know that they're very expensive, but SAMHSA has allowed that SORE grant funding, so your state opioid response grant funding, can be used to pay for these vans. And so that's one avenue. We're keeping our eye on a place and the ways that folks can fund different options, because we know that that's important. Another place to talk about treatment is carceral settings. Recently, CMS approved the 1115 waiver for California, and they have 13 additional waivers in the queue to pay for treatment in carceral settings, and this is 90 days pre-release. It's not just for opioid treatment, for a set of healthcare services, but with this treatment in carceral settings, we know that folks who are re-entering are at a very high risk of overdose and death. So we want to make sure that they're connected to treatment. And so starting treatment within the prison or jail system and then continuing that through re-entry services is very important. And the federal government, through our Bureau of Prisons, our Federal Bureau of Prisons, is actually implementing all three forms of medications across the entire system. So across the entire federal system, which is 122 institutions. And so a large number of them have become OTPs or are becoming OTPs, and they will also provide buprenorphine and naltrexone where appropriate. So this is, us having to be a great example to the states and to the counties, giving everyone the opportunity to use their 1115 waiver authority to cover these medications, and then the Bureau of Prisons, the DEA, and SAMHSA will all be offering technical assistance for states and counties who are seeking to increase access in these settings. So one thing as we talk about treatment, we are trying to use some flexibility by providing more opportunities within the current grant-making systems than states have had in the past. So there's been SORE flexibility, SORE grant flexibility. SORE grants can be used to provide services in carceral settings, which is not available through the substance use block grant. And the 1115 waiver authority has also been used. California, if you haven't seen it, if you haven't looked at it, there's quite a number of advances in California's waiver. And Zoe mentioned telehealth. It is true that the DEA received 38,000 comments. We should note that these are two different telehealth notices of public rulemaking. One that was very specific to buprenorphine and buprenorphine as it was administered during the public health emergency, and the second, which really was something required of DEA as a result of the Ryan Haight Act. And so both of those will continue in the way that they were during the public health emergency, while the DEA addresses the 38,000 comments. By law, they have to address every one of them. So I know that they are painstakingly going through, because the administrator herself has been interested in wanting to make sure that they are looking at all that everyone has sent in, and I know folks have sent in a lot of good research. They've sent in a lot of good experience. So we will have more on that as it evolves. And I shouldn't stop by talking about treatment, because we also need to talk about recovery. And so folks can be in treatment for their entire lives, but they're in recovery. And so we've been working and will continue to work on recovery-based services. We're very excited. We've launched with the Department of Labor a recovery-ready workplace hub for employers. And this provides resources for employers who want to be a recovery-friendly workplace. We know that there's over 20 million people in recovery in the US, and it supports everybody when folks are able to return to work in a setting that is comfortable and accepting. And we are working on, with regard to state flexibilities, we're trying to work with states so that they don't create additional barriers on top of what we're trying to work to decrease the barriers. We've seen some states that are looking at ways to create new registries now that the X waiver has been eliminated. And so we're trying to look toward how we can work with states so that they don't feel the need to add additional barriers on that, we've just really lifted. So we've tried to make everything more accessible. And some of those may have to do with our flexibility with funding, with rules. And before I finish, I just want to plug using your opioid settlement dollars for things that you cannot use a federal dollar for. It's really important. There's a lot of things that treatment providers need in order to get up and running, in order to expand capacity. Some of these things can be used with a federal dollar, which should be maximized first, but then use the opioid settlement dollars really effectively and smartly so that you're not using it where you could really use a federal dollar. And so with that, I'll stop and take questions.
Yeah, thank you so much. That was a whirlwind of many different areas, and very much appreciate it. There's a lot of activity in the chat and the Q&A, and I'll post a couple of those in a moment. But I wonder if, from your perspective, I think early on, 3 years ago, we talked a little bit about how, for all the sort of upheaval and things changing quickly during the early months of COVID, it was also an opportunity for learning and almost a sort of a lab for testing if we could do things differently. And I just wonder, what stands out for you the most in terms of one or two really key pieces of learning that you think will now carry forward into how you and your teams are thinking about this next steps?
Thank you for that. One of the biggest things, and I think when you alluded to it, is that this has been a learning lab for all of us. I have been in this field or related for 35 years now, and I have never seen as much research in this space as I have seen in the past few years. And I keep asking everybody because I think I must just be, dreaming, or, maybe I've missed something, way back when. But seriously, the amount of research that we are seeing in this space is phenomenal, and it's important, and we're really excited for all of it. And we consume all of it like all of you do, and use it to guide our work. I was flipping through, I was recognizing names of folks whose research has just been published that I was reading the other night. And so I think we really are taking all of that in, and we're very appreciative that it's coming out. I think it's also helped the more research and the more we're talking about it, because as we think about the mental health crisis as a result of COVID and the increased substance use as a result of COVID, I think we're starting to see, and I am not a Pollyanna about this by any stretch of the imagination, but I think we're starting to see a little bit of a decrease in stigma, which we all know is just rife in this space. And it's so important to really, in order to get people into treatment, we have to stop stigmatizing them, stigmatizing ourselves, stigmatizing the community. And I think as we're looking, and Zoe pointed out about the research around methadone, like how important is it that we see that people are taking home methadone and they're in, you know, that this diversion that people were so scared of didn't happen. And so this has, you know, really been some of the beauties of COVID and post-COVID, if we have any beauties of COVID at all.
Beth, thank you. And as you mentioned methadone, as you might imagine, there are quite a few questions and comments related to that. You mentioned the bans quickly. We've been supporting some work as well, looking at the patient experience and the variation across states in terms of whether or not things like extended take-home doses were picked up. Can you say a little bit more about, you know, anything you might envision as some of the next steps in terms of taking what we've learned over the last 3 years, kind of looking at opportunities for putting more flexibility, changing the way we use and deliver methadone as a treatment?
Yes, thank you. That definitely, you know, working on how do we expand access. And we know that not every state was quick to take up the take-home dosing, and now that SAMHSA is going to make that permanent, we're very pleased, and we were hoping that that can help inspire states to really expand and move in that area, the OTPs to do that as well. And there are other options, you know, looking at how can we expand access through medication units. So these satellite units that can be associated with an OTP. How can we make sure that you know, making sure that more prisons and jails are actually able to provide methadone, and then looking at what is within our regulatory authority to modernize methadone a little bit more. So there's still a lot of research to be done, but we really are trying to figure out, you know, what can be our next steps to make methadone more accessible.
Thanks, Beth. One more question before we let you go. There was a question around anything else that's particularly focusing on children and youth. We're noting and have seen data in terms of the sharp increase as well in terms of overdose deaths among adolescents. So is that an area where we could be expecting any new initiatives or areas of focus?
Oh, definitely. So in terms of, you know, some of the things that have already happened in the president's budget, there was a lot of funding for the Department of Education and SAMHSA around mental health. And we know that there's also a lot of co-occurring use in mental health issues and some use of substances. So some of that funding would be targeted in that area. In addition, we know that there's a, you know, prevention of overdose prevention. I'm not talking about primary prevention. We are working on primary prevention, but we've started a couple campaigns for overdose prevention directly targeted at youth. So the first one is the Ad Council campaign called The Real Deal on Fentanyl. And it's Real Deal on Fentanyl, all one word, .com. And this is a campaign directed at middle schoolers and high schoolers. And it's pretty interesting. You can go online and view it. And it's really from an education perspective, in that the students are sitting in a classroom and their substitute teacher is a drug dealer. And they talk really honestly with the students about that you don't know where you're getting your drugs from. And, you know, and we don't care about you, we care about our bottom line. There's a second Ad Council campaign that's targeted at high school students, and it's about overdose prevention. And this one uses influencers, so it's not as easy to look it up online. But really, influencers who are sending out messages, and these are folks that have a huge number of followers, and they have the right targeted followers. So they're again mostly in the high school concentration, in the high school age, some a little bit older, 22, 23, 24. But that is the target demographic for this campaign, and it's really these messaging from these influencers. And if you look, there's a lot of influencers online that are having the opposite message. So, you know, telling people, you know, I just used this drug or that drug, and this is how it was, and it was great. And so, this is sort of a counter of influencers who are talking about overdose prevention and carrying naloxone. And so these are two things that are directly targeted at young people.
Great, Beth, thank you so much. And I think ending on that note and a prevention note is really important for us to remember that the whole continuum across prevention, harm reduction, treatment, and recovery. Thank you so much for joining us this afternoon. I know that you will need to be dropping off for your next commitment, but really wonderful to see you. And again, thank you for sharing this discussion with us today.
Thank you all. I appreciate all the work you're all doing. Thank you so much.
Thanks, Beth. I am now going to turn over the moderator role to my program director, Dr. Ken Schatzkes, who's going to take us through the panel discussion and the second question Q&A towards the end of the webinar. Thank you, everyone. Thanks, Ken.
Hey, thank you, Karen. All right, so we're going to thanks everyone again for joining us today. We're going to have 3-4 grantees speak about their experiences during the COVID-19 pandemic. But first, we're going to start with a grantee at California Bridge, Dr. Andrew Herring, who's founder and director of California Bridge, as well as chief of addiction medicine at Alameda Health System. So with that, Andrew, you can take it away.
Hello, thank you to the Fore Foundation and everyone here today. I'm very happy to be here to chat with you about my experience. I'm an emergency physician and as well an addiction specialist. So the COVID-19 was a very, very real and big event in my life in many different ways. The thing that I really would like to, advance slide. The take home of what I'm going to talk about is that telehealth was a complete game changer for people working in the safety net. I think it's important to identify the safety net as a specific area of focus. I mean, we live in a very segregated healthcare system where people working with Medicaid and the safety net have a completely different experience than people working with private insurance. So when I'm talking about telehealth, I'm talking about brick and mortar safety net institutions up training to be able to provide services via telehealth. I'm very specifically not talking about for-profit in the sky entities that are moving into telehealth, which I'm incredibly skeptical of. But in terms of, can telehealth be a game changer for safety net clinics, emergency departments, hospitals, health systems to reach people who are high risk? Absolutely. I think this graph really tells it all. Beginning, you can see here, this is California. This is buprenorphine prescribing. Now, I've been involved with the SOR grants since their inception. We spent hundreds and hundreds of millions of dollars, incredible amounts of work effort to try to increase access to buprenorphine. Now, beginning around 2018. And what we saw is that buprenorphine prescribing actually didn't budge, and if anything, went down, right? So lots and lots of work with very little positive motion. At the same time, overdose rates went up. Now, this is not something we see in science in evaluation very often, when your trend curve literally goes straight up. And this means that the rules of the game were changed. And this was simply the public health emergency removal of the requirement of a face-to-face visit before initiation of MOUD, or of buprenorphine specifically. So this was our experience. So working in all these different ways, and then suddenly you change the rules, and we can create. We have this new ability to reach people wherever they're at, in their car, in the homeless encampment, just getting out of jail. All you need is a phone, and you can connect someone in real time to a physician. So just really digest this graph and try to think in healthcare implementation science is there a parallel? You know, something we've been working on increasing access to MOUD for a long, long time. We've never seen anything close to this kind of effect. So it just speaks to how powerful this is. We don't need new fancy formulations of buprenorphine. We don't need anything too fancy. We just need common sense enabling of providers to use telehealth to reach people efficiently. Next slide, please. So the thing I also want to frame is telehealth can be boiled down to this very reductionist way as a sort of dry mechanism to deliver a pharmacologic product into someone's body. And that's true. It's also a wonderful vehicle for just creating availability and belonging. Two of the huge gaps in the healthcare system is that the healthcare system is built around many conflicting agendas, one of which is clearly to prevent access to entitlements, to actually limit utilization of things that people are entitled to. And these are the so-called barriers, the upfront eligibility testing, upfront intake requirements that are really there to create friction in the system so the ultimate utilization of the resources decreased, so the cost is decreased. What telehealth does is enables you to put upfront harm reductionists, folks who are coming at this from a humanistic, empathic, lived experience perspective, and can offer a person who picks up the phone in real time and is there to problem solve. So when I say telehealth, I'm really thinking of this model where harm reduction and medicine all come together, and you use the simple technology to create real-time availability. So when someone's in crisis or they're just frustrated, they pick up the phone and someone answers. They send a text and someone texts back. And we know from mental health science that creating a sense of belonging is perhaps the single most important intervention that we can do on a large scale for people who are struggling and at risk of suicide. And so this is a good photo of our team right now at Alameda Health System. And I love it because it's what people get when they make a call. Next slide. So just a real snapshot. This is a single line. This is a relatively underfunded county clinic where telehealth completely transformed our world. We now have well over 20,000 calls and texts per year. This has generated over 8,000 visits per year with nearly 2,000 unique patients with a retention of 1,100. And this is a program that when I started, I would see like 30, 40 people once a week. So this kind of expansion was because of telehealth. Next slide. So around the state, now going from Highland and scoping out, there's a simple model, touch points. People come to the ER, it's free, it's 24/7, it's transparent, you know how to get what you need, you wait in line, you will get a doctor, you will get a sandwich, you will get a clean bed. It lacks many of these other sort of complex eligibility tests that are so common in the rest of the system, including the safety net. So it has a really effective draw for people who are struggling and using drugs. We build champions, we install navigators, and we work with patients to enter into long-term care. Telehealth makes this whole work because no matter how many champions we have out there, if they're available 24/7 to initiate buprenorphine, we need an equally flexible, dynamic, and available system outside the ER. And that's what telehealth brings. Next slide. So this front door, that combines medical science or the bioreductionist pharmaceutical model with harm reduction, humanism, meeting people where they're at, just moving them in any incremental way away from harm towards wellness, whether it's naloxone or it's pipes to have safe smoking, or it's safe injection supplies, or it's buprenorphine, or it's dispense methadone, whatever people want. This front door is really just supercharged when you have telehealth, because everybody has problems with all aspects of care. There's always something that goes wrong, and you need a fixer who's on the line. And that's what this is, the essential component of what an ER needs when they leave. Next slide. So the solution is right there in front of us, in the sense that we can't fix the opioid epidemic necessarily overnight, but we really can fix access to buprenorphine, right? Because one of the key things about buprenorphine is probably most of the people who would benefit from it don't necessarily want it in its current form, which is often limited by many barriers and access friction points. And at the same time, many of the people who want it can't get it. So we have to really promote and create this frictionless, aggressive system that's reaching out and connecting people and drawing them into care. Then telehealth is the glue that can make this happen and combine the advantages of a 24/7 acute care setting, of a longitudinal clinic, and then all these myriad touch points, from carceral settings to homeless shelters and street teams. Like, telehealth is really right there to put this together. Any additional barriers to it in terms of these rather arbitrary ideas of what does it really, like, what does it mean to meet someone in person? It's very unclear. What does 30 days mean? What does 60 days mean? What does 90 days mean? These are all arbitrary and really get in the way of a huge amount of people around the country in their own scrappy ways that are pulling together these safety net telehealth systems and saving people's lives in real time. So with that, I'd like to just to conclude and just sort of put forth this vision of why isn't it that every single person in every single state doesn't have a hotline that they can pick up and access MOUD in real time? It's completely possible, and in many ways, it's really just the will of stakeholders that are preventing this from happening right now. Thank you.
Thank you, Dr. Herring. That was a really great overview of the provider perspective and then the work that you've been doing during COVID. So thank you for all the work that you do. Excellent. And with that, we're going to move on to our next speaker. Our next speaker is the new Dr. Danielle Russell from Arizona State University. Dr. Russell has been working with our grantee, Beth Meyerson at the University of Arizona, on studying what was the patient experience during the COVID-19 pandemic. With that, Dr. Russell, you can take it away.
Oh, it's not letting me start my video, but I can unmute. Thank you for that
I
introduction.
got you.
Oh, okay. Thank you.
You're good to go.
Yeah, I guess I just emphasize too, if I hadn't gotten on methadone almost a decade ago, I don't think I would be sitting here at all, much less with several degrees that I've earned since then, including my doctorate. So even though some of the things I'm going to say are a little bit, there's a lot of nuance in the evolution of the client experience. Like overall, methadone itself is such a efficacious modality and like support for people who are opioid dependent. So I'm going to talk a little bit about our fore-funded mood study. It involved 1 hour audio recorded field interviews conducted with 131 people who were either on methadone or buprenorphine at some point during COVID. And so I know that's kind of murky, what is during COVID, but so for us, this was between January 1st, 2020 and March 31st, 2021. So that was pretty much like when it was still officially labeled the pandemic. And then the interviews were conducted between August 1st and October 10th of 2021. So I'll start there. Telehealth was reported by 71% of our participants. This was a little more nuanced for people on methadone though, because the majority were required to come into the clinic physically. So they would come into the clinic and the providers would be offsite, somewhere where they're safe and like not exposed to the crowded clinic and potentially getting COVID. And I'll talk a little bit more about that here in a second. We also looked at risk for severe COVID outcomes in our cohort, and this was reported by 40.5% of our sample were at risk for severe COVID outcomes. And we think about that along with this number, almost about 40% of methadone clients were required to be at the clinic daily to get medication. And 47.6% of that 40% were also at high risk for COVID severe outcomes. So you can see how like the telehealth allowance that we can presume in spirit was meant to protect this vulnerable population of people on methadone Instead, it was utilized more to protect providers and their needs and concerns, because they were still there every day. And then as far as decreased drug testing, it was kind of hard to get a hold on how many people experienced decreased drug testing because it wasn't announced. But I can tell you that I did a UDS every week of 2021 until my clinic was bought by a new clinic. And then I suddenly was no longer drug tested every week, and I got monthly take homes immediately. So it's just not a lot of consistency between, it just kind of depends on the provider and their protocol, which it's not necessarily tied to anything rational. And, we saw that in our study as well, is, people reporting like a wide range of experiences. But yeah, it's been a good 5 years since I had anything interesting in my drug screens. But then also there's a profit incentive because I'm also on Medicare. And so my sense based on the bills that I see was that was what was motivating my weekly UDS more than anything else. And then about half of the methadone patients indicated that they did hear that there were take-home, like multi-day take-homes going on at their clinic. And about 45% were offered an extra day or two of multi-day doses. We heard a lot of people getting tri-weekly pickups. That would mean they came in 3 times a week, but no one in our study actually indicated that they received the federally allowed 14 or 28-day take-homes for unstable and stable clients, respectively. And then despite no one getting those 14 days for unstable or the 28 days for stable clients outlined by the federal regulatory changes, participants were joyous about the additional take homes. 100% of the people interviewed were super happy to have that extra time to eat breakfast with their kids, enjoy holiday mornings with their family, less interruption of work schedules, and just feeling human again. And 100% of the people, we had a question in our study that asked if you could wave a magic wand and improve how you access methadone or buprenorphine, 100% responded they would like that it delivered to their home or more take homes, people just desiring more autonomy and agency over their own lives. Unfortunately, and we see kind of the evolution of these federal regulatory changes already, the joy was short-lived for a lot of people here in Arizona. Even at that time, back in October 2021, the pandemic was still officially raging. 12.2% of the people in our study indicated that the accommodations had already been rescinded. And that number is really low because we didn't actually ask directly, like, hey, have these changes that we're asking about, did they stop them yet? It was just organically offered because people were so angry because they'd like tasted freedom and, no longer being infantilized, and they liked it, surprise. But so yeah, they were really angry. They brought up organically. So that 12.2% is likely really low because we didn't ask everyone. This is just the people who brought it up and told us, like, we want you to know. So that's pretty high for like mid to early pandemic. And then additionally, we looked at who was reporting the accommodations were already rescinded, and 62.5% of the people reporting loss of accommodations were people in that cohort for high risk for COVID complications. So this shows us that being high risk for COVID complications wasn't being considered in the majority of the people who were getting the accommodations. So part of our study involved forming a community board with people on methadone and methadone providers. This included an owner of one of the largest methadone franchises in the country. When we asked about why there was so much like rescinding of some of these accommodations, it was indicated that a lot of the clinics were hemorrhaging money. The business model of the clinic is established around having clients on site as often as possible, stacking charges on accounts. So you can't do this if people aren't on site. The charges have to sync to the dates the client is on site for audits. So based on that 12.2% of rescinding of accommodations we saw in 22, we can only reason that there are very few clinics who are continuing to implement these take-home accommodations now. And these numbers I'm sharing more from methadone. I know bup is its own different thing. It's kind of like the teacher's pet of the ORT drugs. So I think, kind of getting like worst case picture by looking at methadone, which I think is important. And then so what we saw the clinics doing with the telehealth was to accommodate their business model needs through this accommodation. So the 71% of participants who did experience this telehealth accommodation and were required to come to the clinic to attend the video appointments with their offsite provider, excuse me, yeah, they weren't able to stay in their own homes, even if they're high risk, elderly, HIV positive, immunocompromised. They're still coming into crowded clinics in person nearly every day throughout the pandemic. And then I know this might seem kind of jarringly different here, but I really want to end by talking about, something positive and what the future could look like, and how methadone access looks different elsewhere outside of the US. As you've heard, I just graduated. I'm going to be doing a postdoc at the University of New South Wales in Sydney. And so I've been traveling a bit, going down there to Sydney. I was there last month for a conference. And I've really, this traveling has allowed me to realize how the US is such a dangerous place to be if you're an individual who needs treatment, not just RIT, but like really any medical treatment of any kind. So especially as I age and become more vulnerable, I want to be somewhere where I can access medical care a little easier. But yeah, so I talked to people while I was there who are on methadone in Australia. I talked to people who are on methadone for 7 to 10 years. They were drug tested once when they first entered treatment. And this blew my mind because the kind of mirrors in the toilet, like random strange man watching you urinate kind of experience that is US methadone, comparatively, like they couldn't even fathom like mirrors in the toilet. I swear, I think they thought like I was making it up because their looks were like abject horror that this is what goes on here. And then there was one specific experience that also blew my mind. I'm in Sydney. My friend calls me. She lives out in the suburbs, about an hour away on the train. And she's, her daughter is autistic. She was having some issues with her daughter and didn't want to leave her house. And she asked me, hey, you're in Sydney. Can you swing by my pharmacy? Here's the address and pick up my methadone for me. This, is coming from the US. This sounds very weird. I was like, what do you mean pick up your methadone for you? And she was like, yeah, I already called. I told him I'm going to have a friend coming in to get my methadone, and bring it out to me because, I want to take care of my daughter today. One, like you would never, especially as a mother, like you would never get your needs accommodated just because you have family needs. I mean, you could end up like dying and unconscious in a hospital and no one is going to pick up my methadone for me. Like, yeah, so it was crazy. So I go to the pharmacy, I trust her, so I'm not going to get arrested. And, I go in the pharmacy, I say, I'm here for blah, blah, blah's medication. They're like, sure, have a seat. They give me a cup of water. They got a nice little waiting room. And then boom, they give me the bag and they're like, have a nice day. And it was so normal and human and foreign to anything I've experienced here. Especially looking back, like I've been so thankful to have access to methadone because it has, facilitated me having this extra stability in my life. And especially in the first couple of years, you're just happy for any crumbs because you're lucky that you are surviving here in the environment that is like the US drug scene, treatment scene. You're just happy to be alive and you're lucky. But yeah, so then as you spend more time, especially going to school, you start getting a sense of self-confidence and self-worth back that like, hey, maybe I don't deserve to be punched in the face every day. It becomes harder. And especially, I'm almost 40, I'm an adult woman. I don't believe I should have to ask random medical providers when I travel for permission. It becomes harder. So I think that's just what I want to end on is it is possible to implement these resources in a way that's kind and respects people's dignity. Because I've seen it. It's totally possible. And that hurts. It hurts so bad. It's hard to explain why it hurts so bad to see that. But it did, because it's like, I think about all the people I know here that they can't access methadone, or that like people that are like trying really hard to make BUP work because it's like the loophole out of the abuse of methadone access. And it's just so hard. Like, I don't even tell friends to try anymore because I feel like I'm setting them up for failure. Because when I talk to someone, I'm already going through the list of reasons they won't be able to access this. You don't have a car, boom, done. You don't have a car, don't try. Like, it's, you're not going to make it every day. You're just going to like torture yourself. You're not going to make it to all appointments, the hoops to jump through. Especially if somebody's got other mental health issues where they're struggling to remember days and dates and stuff like that, which fentanyl tends to kind of exacerbate those issues as well. So yeah, I just, I just I don't feel too hopeful about the US, and I do I feel bad about running out. But yeah, that's all I have to say. Thank you.
Danielle, that just thank you so much for sharing that, not only your research, but your own experiences and perspective on this. It's so important to hear, what patients are dealing with, on a daily basis here, and what could be in this country, and the way that we could set up our health system for people to be successful in their treatment and to provide them, a sense of dignity while they go through that. So just thank you, thank you, thank you. All right, all right. With that, I am going to pass it on to our next speaker, Hemi Tourson, who's the executive director at our grantee at the National Academy for State Health Policy. That's a tough one to follow up, Hemi. So good luck on that one.
Thank you, Ken. And it's really a privilege to be here with all of you. And Danielle, really, it's heartfelt, sort of personal stories that you share. So you are very hard to follow, but I'm going to do my best. So I just wanted to just provide a state perspective from the work that we do here at NASHB. For those of you that are not familiar with NASHB, we are a nonprofit organization that really, our mission is to improve the health of people across every state. And we work with all states, red, blue, purple, and a lot of different types of state leaders. So we're not like a typical association. We really are sort of a center for best practices, where we really get states together, whether they're legislators or governor's offices or Medicaid officials or public health officials or social services agencies, or the behavioral health providers, to really come together and understand how can they really improve the health of the people that they're serving. So that's our mission, and that's who we are. And so I just wanted to share that as background of what I'm going to talk about today. So NASHB has, in partnership with fore, has really spent a number of years really focusing on how we really help states improve their system of care for those individuals who have opioid use disorder. And I'll say, me personally, I have worked over 20 years in state health policy, and our, to Danielle's point, our healthcare system is very complicated. I learn new things every day, and I scratch my head every day about how, we can think about doing things better. So I'm not here to say, here's, the story about how everything is going to be solved, but really I just wanted to provide some reflections on what states have been thinking about during this pandemic, and kind of what's on the other side of really how we get our arms around and do better to really help people who have opioid use disorder and substance use disorder more generally. So, thinking about the opioid crisis, and in full disclosure, I've been here at NASHB for 2 years working on this topic, but I also worked on this topic when I was at the National Governors Association for many years, and opioid use disorder was at the top of the list in terms of governor's priorities. So this is not a new topic, but I really think there's a lot that we have experienced and learned as part of this pandemic that I really hope, I'm a glass half full person, so I'll just say that I really hope we can apply those lessons and really do better, and really be able to make progress and help people who really need it. When I think about the opioid crisis, and I will continue to use that word, I really think it extends beyond the boundaries of our traditional state health systems. And we really need to be thinking about how we can require evidence-based treatment and coordination between state agencies and leaders. It's not, one agency, one person is not going to solve this. It's really working collaboratively to think about what's going to actually improve the care that we're providing, and the access that people need. I think that's really key. So here at NASHB, we've been working with states, again, across the country, to develop really a no wrong door approach to treatment that prioritizes cross-system policies, enhances systems of care, and improves the continuum of care for people with opioid use disorder. And we really do that through providing tools and resources that share best practices and promising approaches in our State Policy Center for Opioid Use Disorder Treatment and Access. And that includes, what I'll talk about a little bit later, is how states are spending opioid settlement dollars, which I think is an opportunity that I hope we really can leverage as we move forward. So just in reflecting sort of what states experienced during the pandemic, and sort of they're running the system, and they're at the system level, I think they had a lot of challenges. There was a lot of work they did to expand treatment during what was really a dual epidemic of ongoing opioid crisis and the COVID-19 pandemic itself. Coming out of the pandemic, we've seen a surge, unfortunately, and overdose deaths, and also mental health needs. So behavioral health as a topic is top of the list in terms of priority areas for states, both on the executive branch side and the legislative branch side. And we're reflecting that here in Nashville by really investing a lot of our time in this work. And there's a couple of things that really were at the top of the list in terms of challenges. One was, people in isolation, how do we reach them? And, we heard a lot about, the use of telehealth and a new way of providing care. We all had to learn how to do that. But I think there were also people that were not reached during the pandemic, or there were other challenges during the pandemic, which is why we're seeing the continued rise in overdose rates. States had workforce challenges and capacity challenges. That was coupled with increased federal resources to expand access to care, and states use that to build infrastructure to strengthen the care that they can provide and meet people where they are. But I think a lot more work needs to be done in order to really understand community voices and bring those voices into how you can really find solutions to where we can do better. So I just want to talk about a couple of things moving forward, Ken, and then I'll turn it back to you because I know we're getting short on time. So one is just talking a little bit about, we're at the end of the public health emergency, but we coupled with that was the Medicaid unwind. And the Medicaid unwind started before this month. It started back in April, where we're going to see between 5 million and 17 million, the number still to be determined, who could become uninsured. That is a massive amount of people who are going to have to be redetermined to see if they were still eligible for the Medicaid program. Because during the pandemic, people remained eligible because that was part of federal statutory change to ensure that people would not lose coverage during the pandemic. So states are now going through this process, and they're just starting. We're in the beginning of the process with 5 states starting out ahead, but over the next 12 months, all the states are going to be redetermining people who are on their Medicaid rolls to see if they remain eligible. So that is going to be a huge challenge for states and for people who have had coverage for the last couple of years and who may no longer have that. With respect to opioid use disorder, really losing access to coverage for treatment, to Danielle's point, could be devastating. So really understanding and making sure people who remain eligible stay on the rolls, and for those that who are not are able to transition to other sources of coverage really should be a priority for states and the people who serve them. I think the other thing looking forward where we really can make improvements on and do better is building partnerships with community groups and people, really bringing people's voices into our care. And that's true for a lot of different ways that we're providing care, and making sure there's no wrong door and that people can get the access that they need. I think the other piece that we are seeing is there are widening disparities in overdose deaths across racial and ethnic populations. And there's some data that is trying to, some studies and data that trying to explain those disparities and why those are widening. And some data is pointing to really the impact of social determinants of health and how that really impedes access to care. And so states are trying to do more to invest in social supports, such as housing, that I think are really critical to recovery. And we really need to, I think, do more of that and make sure that as states, get, big waivers approved and allow for more flexibility in how Medicaid can cover those services, that is then effectively translated to the people that are actually can benefit from those expanded capabilities. The other thing I will note is people coming out of incarceration. We know those individuals are at higher risk for overdose, along with people who have already had an experience in emergency room and had an overdose. And so really doubling down on providing services to people in the emergency departments and people coming out of prisons is really important. There is a trend in states of wanting to expand Medicaid coverage for those who are incarcerated. California is the first state to get approval from CMS to have that flexibility to provide coverage of Medicaid for incarcerated individuals. And there's 14 states who have waivers that are pending. So I think that's another piece to look forward to, and how to make sure that treatment for opioid use disorder is part of the package of services for people who are transitioning, assuming this actually comes to pass for all those other states. I think just a couple of things, and I'll turn it back to you, Ken. Just remove the X waiver, I think, is a big opportunity to expand access to buprenorphine in primary care and other settings. But how do we really increase greater adoption? I think states are really trying to think about that. It's not just the removal of the waiver itself, but really working with providers to make sure they're going to be willing and able to provide that to the people that need it. And I think, we have polysubstance challenge. So states have been talking to us about how do we really craft better strategies to support people who are struggling with methamphetamine and stimulants, and you know, are there things like, you know, leveraging contingency management as an effective tool, and what other treatments and options do we have to help people who have a polysubstance challenges? And then two last things, then I'll turn it back to you, Ken, is workforce. I think states are struggling across the board with making sure they have a robust workforce to really serve the needs of the people that we know are right now lacking access. And so states are thinking about different types of workers, what they have been all along, but really doubling down on that with peer supports, linkages with CBOs, the CCBHCs or certified community behavioral health centers that are now emerging as a source of care and access, and more community-based workforce. And then finally, I'll just end on this, and we can go into any more detail that you all may want to in the conversation. The opioid settlement funds, I think there's an opportunity here with the close to $50 billion that are flowing to states and localities of really how to use those funds to really address the gaps. And, you know, there's a lot of opportunity to make sure that we leverage those funds so that we can do better. So Ken, I'll probably turn it back to you and we can go to the discussion.
Fantastic. And we're going to bring back all of our speakers for this Q&A. Thank you again to the three of you for fantastic perspectives on what has happened during the pandemic. And I'm going to start the conversation with Dr. Herring. And you know, you spoke about telehealth and how it was so important for the safety net in our healthcare system. And I'm curious, you know, to hear a little bit about, from your perspective as a provider and a researcher, to what extent, you know, these pandemic era changes, the flexibilities, how they've expanded and democratized access to treatment.
Yeah, thank you. So again, you know, early in this work, working with emergency departments and health systems who are a classic 24/7 touch point, reaching people and then trying to get them into care, whether it's methadone or buprenorphine, you're stuck with, okay, where are these people going to go?
Yeah.
You know, in swoop the telehealth companies to say, hey, you know, local public health department, local behavioral healthcare services department, you don't need to invest in brick and mortar changes to your system to create access. Just put the contract on us and we'll do it. Knowing full well there's really no actual Medicaid financial revenue market that makes sense aside from urine drug testing for these companies. So that's actually terrible, right? So that will lead to undermining real progress in the American healthcare system. The converse of actually, you know, working with underpaid, under-resourced county clinics and hospitals who are trying to create access for folks who have all these various limitations that we've talked about. It's amazing, right? It's just because telehealth is very, very easy. It's cheap. You know, all you need is literally a computer and a phone. With public support, you can often get phones to people who might not have very many other possessions aside from the phone, and build a whole ecosystem of care when you start linking together the various folks powered by tele. So that's why you see these numbers, they don't just go up, you know, they skyrocket. So at some level, this should be something that all of us are just cheering. I mean, it's totally unprecedented in the rapidity with which we broaden the scope of access to buprenorphine to some of our highest risk people.
Agreed. Yeah, I don't think that there was ever a time where you've had this many policy changes, flexible or permanent, happen around this space in such a short amount of time. I want to move on to Dr. Russell, and you know, you spoke a little bit about, you know, the research that you did in Arizona around the flexibilities, you know, as well as your own experience, and you know how it was limited, you know, those regulatory changes. And can you speak a little bit to, you know, how culture, you know, whether it's an organization, you know, society, a community, how important cultural changes and shifts are when you include it with policy changes to change hearts and minds to address stigma and to improve the system?
That's such a good question. I talked to Dr. Beth Meyerson about this a lot, like theories of change and how you help implement like a cultural shift, especially in an organization like a clinic, or how people view people on methadone. I'm not like, I definitely don't have like a golden answer to solve everything, but I think part of it is even letting the people that work at the clinics, I don't know if they need more training, or like it is like the stigma, like their hatred is palpable sometimes, like especially like the front office, and almost like you see nurses come in and they're nice at first, and within a couple months, I don't know what happens, but it's something about the assembly line like process with which we come in, and they're probably seeing so much suffering and trauma just shotgunned at them over and over, that they like rapidly become desensitized and start to see us all as just like a big mess. And I think that's why I think even kind of expanding access outside of the clinic is so important, because it like having it all isolated in this one space where all of this suffering is concentrated, like that increases the stigma. And it also puts so much power in the hands of this few people, that like that power imbalance is so severe that like I don't know that you could get past it in that environment. So and that's part of why I think Australia is a little bit better, is because it is, the power is more fractured. It's not all just concentrated in one silo of the OTP, which
Yeah, no, I completely agree. I think one of the things that we saw in New York during the pandemic was that organizations that provided methadone, that had that cultural shift, that had that ideas around harm reduction, and staff really believing in that, were higher performing and provided more flexibilities than those that did not. So we see that around the country as well. Hemi, you alluded a little bit at the end about the opioid settlement funds, and really, what we could be using it for. And we know that these federal flexibilities we're talking about are necessary, but they're not sufficient. So what else, in your viewpoint, needs to happen, and how are opioid settlement dollars filling that gap and addressing some of these needs?
Yeah, I'm going to say, I think we have such an opportunity. So I hope that the dollars go to where we want them to go, and they're going to really make a difference. So there are a couple of areas. One is just treatment programs, specifically MOUD. Having more resources for those programs, I think, are really important and can help to increase access, especially when we have people who may be losing coverage on the Medicaid side. So really important piece there. Harm reduction. So we have seen a real shift in thinking around harm reduction and the importance of syringe services programs. I worked on a project when I was at NGA years ago, and it was really hard in conservative states to talk about sort of that as an option. And it really is changing in the conversation. So I think, and there are states that are using these dollars to invest in those services and think about how to expand the capacity. Supportive housing. I talked about how housing is really critical part of recovery. I mean, you have to have a home in order to think about how you even can really recover and do all the things you want to do, and not be worried about being homeless and unstable in that way. And so you see some states dedicating some of these resources to supportive housing. Prevention campaigns is on the list too. I know this conversation is more about the treatment side, but prevention, I think, is also important. And really important, especially for certain subpopulations that we know could really benefit from that. Infrastructure development, including new facilities. I think that could be relevant for filling the gap of really how do we create more access and make it a place where communities can help inform how services can be provided and will really utilize them. So I think those are just a couple of examples, but I think all of that is going to be important to make sure, what localities invest in versus what states invest in, and making sure that all of that is complementary and sustainable as part of the challenge in all of this.
And it'll be so important, that oversight of those dollars, and making sure that it's going to be
people
used for things that are really necessary. Great. We'll go back around to Dr. Herring, and just ask you. You framed a lot of the discussion and barriers right now as arbitrary. It's this, we should just be doing the right thing. So what do you see as the biggest challenge challenge in this emerging treatment regulatory environment as we try to get to a point where we feel that there's a no wrong door approach and everyone could reach treatment?
It's a very complicated question. I think that Dr. Russell, I think, did really hit on the degree to which mechanisms that are fundamentally designed to exclude become internalized and normalized amongst caregivers. So they don't even really have necessarily an awareness that they're acting out what is fundamentally an exclusionary action. They think they're doing the right thing. They think it makes sense to screen people for insurance.
Yeah.
They think it makes sense that we should be making sure that you got your ID and it's valid before you get your medicine. All these sort of things, that there's this common sense to it. That when you step back and you look at other countries, other systems, it all evaporates. And you're like, oh my God, this is a human being with a medical condition who's in acute suffering, and you're just getting in the way of an entitlement to which they deserve and have rights to. So it's, stigma is often framed in a little bit kind of like, oh, do you like people who use drugs? Do you not like, but this is hardcore. This is structural. And I think that to really match the scale of what happened with opioids, we need a really honest and large scale deconstruction of these fundamentally segregationist type policies that push away low income people from entitlements to which they deserve.
Yep, and look at those new ideas that we could bring in to make it easier. So, I want to go to Dr. Russell about this as someone that actually, attended our pharmacy advisory meeting, thinking about a better way and how other providers may be able to be involved in increasing access to MOUD. We have one question from the audience about what could be the role of community pharmacists, for starting, continuing MOUD, whether that's buprenorphine, methadone, considering that there's been some successes of this model during COVID as well.
It's the differences I saw when I was in Australia too. It's like, I guess all healthcare delivery in the US is so assembly line. So we did a secret shopper study, Dr. Myerson and myself in a research team, where we sent secret shoppers into pharmacies to ask to buy sterile syringes. And if they're asked why, to say, I need them to protect myself from HIV and hepatitis C. And you were still told no, like even with that. So it really emphasized how pharmacies here, they don't view themselves, even the community in the pharmacy, like they don't view themselves as part of the community. And some of them would even say directly to our secret shoppers, we don't sell them because there's a big need in the community for them. So the inverse of like, there was a lot of need in those, because we geomapped from like 2 miles from like drug copying zones too. So they were all high need neighborhoods. But so I mean, I guess, I don't know how you could, slow down pharmacies. So like what I saw in Australia, you go in and it's actually people, it's family owned. Like I could tell it was a father and son in the pharmacy I picked up at. Well, their names match too, so it's pretty obvious. And you just don't really see that here. And I don't know that I would ever recognize a pharmacist when I go in. It's like I'll pick up wherever the thing gets sent, there's not a lot of individual communication going on. So I think just maybe reordering of how healthcare works, but that's a big task. So
Very, very big task, but I think it's something that we're looking at as well at fore about how do we involve everyone in the solution, because it will take everybody. Hemi, another question to you. NASHP is building, a number of tools, TA to states, so just wanted you to talk a little bit about what types of tools and TA are states going to need to address, really the coordination challenges that they're going to have through different multiple funding streams happening, different regulatory changes happening. Can you speak a little bit about that?
Yeah, I've worked with states for a long time, and I really feel like one of the keys is holding out those states that are probably ahead of the curve and really thinking about where they're making progress. And they never feel like they solve it because these are really big challenges, but where they're making progress and their real interest of sharing with other states about what they've tried, what they've learned. And so I feel like that's a huge source of value for states really sharing. And I'm not even going to say best practices, promising practices right now, whether not just in like, how they're using the opioid settlement funding, but also some of the other things that we've talked about earlier in this webinar about, how to bring in community and these other, ideas around social supports and services and how you're trying to really address, polysubstance use. And here at NASHB, we have virtual convenings, in-person convenings, papers, blogs, having states, just be in a closed door to just talk to one another. And I think it's such an important time for them to have that space, because when you're working on so much, we all have like our things that we're responsible for, and it's the volume and the challenges are so hard to pick up your head and say, what is happening across the country that I can learn from? So that's, I think, really an important piece of all of this, and really to continue to share that.
Great. Well, I have a few minutes left, so I'm going to start to wrap us up, but I just want to say thank you again to all three of you and all of our speakers today, Beth Connolly as well at the ONDCP, as well as Zoe Bernard at Manat. This has been an incredible conversation from so many different perspectives, and we're going to continue this here at Fore. We'll let everybody know that we have an issue brief that will be released soon, actually on what happens after the COVID-19 PHE ending, and kind of summarize a lot of what we discussed today. And that will be available on our website in the coming week or so. As always, feel free to reach out to us with any questions or anything, and hope everyone has a great day. Thank you, everyone.